Good noon, everyone. I am Keshav Singh representing Patient Academy for Innovation and Research. I hope you all are doing well. On behalf of Dakshani and Amravati Health Education and Patient Academy for Innovation and Research, I would like to welcome you in today's webinar, Empowering Patient in Diagnostic Safety. Thank you for joining us. There will be my team member, Dr. Ria Agarwal is also joined. So we both want to welcome you all on behalf of our whole organization. And as you know, every year on 17th of September, the World Health Organization commemorate World Patient Safety Day, highlighting the different themes annually. And there are several activity all over the world happening from the date of the announcement. This year, the theme is improving diagnosis for patient safety. Care Academy, along with Patient for Patient Safety Network Asia Pacific, which is our initiative, and Dakshama Health have planned a series of 6 webinars around this theme. And this is the sixth webinar, the last one of the series, theme empowering patient in diagnostic safety. Diagnostic safety encompasses a broad scope of concern as approximately 70% of clinical decisions are informed by laboratory results. Gaining perspective from laboratories, nurses, specialists, and patient organization can offer new insight to ensuring the quality standards and accreditation. This webinar will hopefully serve as a platform to delve into the complexities of diagnostic safety, uncovering the strategies to improve patient outcomes, and enhancing the overall quality of care. By working together and listening to everyone's idea, we will ensure patients receive the right diagnostic and safe during the diagnostic procedures. So I'm pleased to introduce our esteemed panel of speakers who will share their insight and expertise on the critical topics. So, on the first panel, on the first speaking slot, we have Miss Mridula Kapil Bhargava. Miss Mridula has is dedicated public health professional and the founder of Diabetes Fighter Trust. She has over 10 years of experience in healthcare and has worked in various roles, including team lead, public health consultant, and program manager. Mridula holds a degree in biotechnology and postgraduate degree in nanobiotechnology. Some of her notable achievements including being among of top 50 leaders in the Novartis Leadership Camp 2013, a cover feature in the Week magazine, and being on the top 15 inventors in the Intel DST Digital India Challenge 2015. She also received the Backend Invention Award in 2017 and 2018. We welcome you, Brilla, in this panel. Uh, then we have Miss Seema Nairani. She has experienced quality and regulatory professional with more than 25 years. She has also experience in diagnostic medical device, pharma, dairy, and public testing laboratories. Then currently, Ms. Seema had heads the product quality and safety function in Roche Diagnostic India Private Limited and manages India as well as Nepal, Bangladesh, Sri Lanka, Bhutan markets. Then in Miss Seema has Six Sigma black belt champion and has tough through understanding all the aspect of DMAIC model in accordance with Six Sigma principles. We are honored to welcome you, ma'am. Can we have the next slide, please? Then we have Dr. Mahesh Devnani. Dr. Devnani is an additional professor of hospital administration and joint medical superintendent at Postgraduate Institute of Medical and Research, uh, Chandigarh, PGI Chandigarh. He is a physician turned hospital administrator, having more than 18 years of progressive professional experience in the field of medicine, public health, and healthcare administration. He is also a alumni of SAT Business School, University of Oxford, where he pursued a science and innovation leadership program on Clevering Fellowship. We welcome you, sir. Sir is not joining yet, but he is joining in some time. So we welcome you, Dr. Mahesh. And then I want to hand over the stage to Mridla to get the first slot. And stage is all yours, Mridla. Thank you.
Thank you so much, Keshav, and I'm so glad that I'll be talking about a topic that is very close to my heart, and you'll gradually all understand why did I say so. So I was diagnosed with type 1 diabetes at the age of 4, where when I didn't know anything about it, my parents didn't know anything about it, no internet was there. It was back in 1992, and without internet, without support group, without WhatsApp and everything, it becomes very difficult for any individual to understand about a medical condition, which is now very easy to access all the information, all the details that we want, or even if we want to connect to a doctor. Gradually, I took up the charge, and I decided that I want to work something in the field of diabetes. And it was back in 2013 when I came to know that a girl I knew, and she was based in Punjab, she was no more because her grandparents didn't allow her to take insulin injections. The acceptance was a big challenge over there. She was coming from a village, and actually consulting at base hospital Chandigarh. And it became like a shock to me because there are several things involved over here. Stigma that the person and the family had around insulin injections, that if my uh, you know granddaughter takes insulin injections, she won't be marriage material, she won't get married to any one. Another part is misinformation. The grandparents wanted her to switch to Ayurvedic medicines and not the insulin, that is the only treatment for type 1 diabetes. And then comes the out of pocket expenditure. Of course, that expenditure, the amount that that individual has to pay out of pocket to manage their condition, it takes a big toll on not just that individual who is living with that condition, but also to the whole entire family. So before I start talking about patient education and empowerment, I want to highlight about health literacy. What is health literacy, and why is it important? So there have been more than 250 definitions for health literacy till date, and it has been flexed according to everyone's convenience. And recently, February 2024, WHO launched the collaborating center for health literacy, and mentioning that this health literacy has to be prioritized in every country and at every level of public health intervention. Now, why am I talking about this health literacy is because now it is defined as not just an individual's personal knowledge, but also the resources and tools that individual has, and the organizational structure or environment that individual is present into. So this actually tells us that one individual, like that girl who didn't survive, if they had the right tools to understand why it is important to take insulin injections and follow the treatment that has been prescribed, and the environment, her family being supportive and not stigmatizing the whole condition, would have let that girl survive and thrive till date. And now, coming to why this patient education and empowerment is important. So back when I got to know about this girl, I thought I knew about my medical condition and my challenges. But what about the community? What about the people in my country who might be living with the same condition? They might have different challenges. So I started reaching out to other people living with type 1 diabetes, and made a kind of a support group first, and then an organization called Diabetes Fighters Trust. This patient support group actually provides the community to talk to each other, interact with each other, and lead and own their own medical condition. The best part is that when community and an individual takes ownership of their medical condition, it really helps them manage their condition, self manage their condition, and also adhere with the treatment, and also connect with their doctors, get regular tests and all. Let's say, for example, uh, a person living with type 1 diabetes comes from a family where maybe lower middle income class, and might not have funds to take care of everything, and the treatment that has been prescribed. That individual at last is going to basically ration their insulin, maybe their test strips, their needles. Now what happens if they are using the same insulin syringe or needle? They might land up having lipohypertrophy. Lipohypertrophy is basically, using the same needle which gets blunt, using the same spot to inject insulin, and that particular area then becomes resistant. That area cannot be used further, or can absorb insulin properly. They'll have delayed hypoglycemias and hyperglycemias throughout. And reaching out to doctors again, might take a lot of time for them to go to the hospital or clinic, unless there's a big challenge, or they have not been able to manage their condition. They might not even go there. But when it is happening, when they find out that it is not able to manage, or there's an emergency, they reach out to the doctor, and the doctor prescribes them with higher doses of insulin, or self monitoring, close monitoring. Maybe they'll put the patient on sensor or something like that. Now that adds up, that totally adds up to the already existing cost that the patient is bearing. Why am I saying all of this? Is because we, as healthcare professionals, or as the family of a person living with a chronic medical condition, need to understand the status of mental well-being of that individual who has been recently diagnosed with a medical condition. His or her life is going to totally change. We also need to understand the literacy level. We might know a lot about that condition. We might be even good in presenting or telling the patient about everything, how to manage the condition, or change the needle every day, or change the spots, or rotation should be there for insulin injections. So all of this knowledge is good, but are they even able to grasp it? Do they even have that level of understanding of what the other person is saying, the language that they are communicating in? If I am well versed with English, I might be able to get grasp it. But if I can only speak Hindi, but the other person is using some jargons and language that is not clear to me, it basically kind of resists and kind of becomes a barrier to the proper diagnosis or proper patient safety techniques that the individual might need when they go back home. And again, as I said, the surrounding environment, it's not just that individual who is living with that condition, it is also his or her caregiver or the entire family who needs to be educated. So there are many doctors and experts. When a person is diagnosed with type 1 diabetes, they not just demonstrate that individual on how to take insulin injections, but also demonstrate the parents to take insulin injection themselves on their body, so that they can understand that the needle might not be that painful or not at all painful, as much as they kind of have that in mind, that okay, this might be very challenging for us, this might be very painful for my child. So this is something where we need to interact, need to bring everyone together when we are talking to each other. Just a minute. Hello.
Your screen turns black and white, Ritra.
I don't know. Yeah, there was some internet connection. Uh, yeah.
Yeah, now it's
Yes,
good.
yes. So all of this needs to be taken care of, that as a person enters inside a clinic or a hospital, their mental well-being is first understood, their literacy level, social status, surrounding environment, and then also the health literacy that should be monitored closely for better acceptance of their medical condition, for better understanding of why it is important for regular checkups, why is it important to go and get their tests done every 3 months for maybe their HbA1c, or it could be other tests. Why is it important that they should also take ownership of their condition and self manage and adhere to whatever treatment has been provided. The last thing that I want to mention is that a patient's journey starts from awareness, then we have to screen. And by we, it means that as a family, or also as a healthcare professional, we have to make sure that we are screening and following up with that person or family. Then is the diagnosis. Closely we are going for the tests, and also anything that has not been diagnosed earlier, we must make sure that let's say a person living with type 1 diabetes might also be susceptible to, or might also in future might have challenges with thyroid, or might have celiac disease. So they need to make sure that they are aware and also get themselves checked. The treatment that they are taking with the doctor, it is not just one way communication. They have to interact and ask questions from the doctor. It is not a bad thing if you're asking as many questions as you have from the doctor. And if the doctor is not able to answer, try to talking to your educator, counselor, which might be there in that room. If not, then you definitely need to switch to another one. And then this is something where we can either have just two ways: either we can control a particular medical condition, or we can remission it. We can get back to something that uh, comes under the target range. Maybe it could be related to obesity. So when we adhere to what doctor says, follow a proper lifestyle, exercise, diet, and everything, we will definitely get back to the target weight that we, or the healthy weight that we are looking forward to. Yeah, and in case there is a condition that needs a proper control, we definitely need to make it patient centric and with open discussions. So I'll stop here. Thank you so much.
Thank you so much, Mritla. Thank you. You nicely explain, the stigma, the knowledge, how the patient can get the proper diagnostic service, the patient safety kind of thing. As you are a patient advocate and a patient also, you nicely explain the whole thing, how to empower and how to educate them to get the best advices and best diagnostic, procedures. So thank you so much. We can have the question in the end. If somebody have the question, you may just put it on chat box or the question answer part of it. So then I would like to invite Miss Seema Nirani, as ma'am is head of product quality and safety at Roche Diagnosis. So ma'am will be delivering the lecture on patient reporting mechanism, post marketing surveillance and tools. So can we have the PPT, Vikas? Yeah. Uh, yeah.
Yeah. Yeah. So good afternoon, everyone. Uh, I hope I'm audible clearly.
Yeah. You are
Yeah.
audible. You are.
Okay. Uh, so basically, for me, I'm delivering on patient reporting mechanism and post marketing service and tool. Uh, See, with respect to the IVD industry, if you see, the currently in India there is really a good revolution. We have a new regulations of medical device regulations. So earlier, otherwise, it was always food and drug cosmetics act, which was like, a way was formulated in 1940 and amended in 1945, is being used even for across all the industries of the medical, or even for the medical devices as well as drugs. Now with the new medical device regulations, uh, we have better controls in India, where we can have better expect better quality products, safe products in India now. Furthermore, safe products in India. Also, for patients, there are good safety mechanisms or reporting mechanisms available, or processes available. uh, as far as currently, as a Roche being a number one IVD company, I would like to share some of the good practices what we have it in Roche, how patient can report their issues here, and how do we deal with the issues or the complaints which come, and how seriously we take those complaints, and how do we identify a safety issue into this, or a quality issue into it, and what are the further actions, how do we do it. uh, so basically, uh, next slide, please. So what we say is complain. It is, it can come in any form. It can be a written form, it can be electronic, can be an oral communication, where the customer or a patient is alleging deficiency related to identity, quality, durability, reliability, safety, effectiveness. So any kind of an issues related to product, when after it is released into the market, it is released for the distribution, that is considered as a complaint. Any kind of an allegation for our products which we are putting it in the market. Now, this can be even any kind of an reports which is included in the scientific journals, where where they say that any kind of a product comparison not giving a right results, between comparison between the two instruments which are reporting results for patients, and showing that Roche is not giving a proper result. So those kinds of in scientific journal issues also should be considered as a complaint, and we have to take actions towards it. uh, Even the labeling issues should be considered as an allegation for the, or a complaint kind of an. And this can come from anywhere, like complaint can come from anywhere. It is when you are talking, even as an employees, when we talk to our of relatives over a phone, when we talk to our friends, we are in the confidence, or we doing any routine work. It can come from social media, it can come from any research activity, it can come from all our customers, patients, even our healthcare providers. So uh, so in Roche we say that be vigilant. Complaint can come from any source, all the sources, any source. When we receive complaint, it is essential we take actions. Next slide. uh, so there has to be a proper mechanism by which customer can approach company for any kind of an issue reporting, and there has to be a robust mechanism where, or a process by which the customer complaint is heard. So for those purposes, we have a 24 by 7 call center support, where customer can log in complaints. There are it is through calls, through chat, through email. Customer can log in their complaints to this call center. Even for the in a company website, we have a process. We have a mechanism where customer can contact us for any various kinds of an activities. Even adverse event is one of the activities. I don't know if it is properly readable, but one of the uh, uh, part is about reporting any kind of an adverse event which he is which he is observed or anything. So that through this particular website they can register. Next slide. Now there, in a call center, like as a company, we receive multiple complaints. Yeah. uh, im- that can be like kind of in a training related issues, uh, or uh, or a handling related issues, or preventive maintenance related issues. But then there are certain issues which really needs an attention, which might have a kind of an reporting requirement, or may have a safety issues related to it. So those complaint we identify as a potential reportable issues, and those are identified based on the allegation which is given by the customer. And those allegations, some indicators which we have defined as, like uh, any kind of a death, public health threat, there is a serious injury, or a serious deterioration of health, or there is any kind of an erroneous results which may lead to a patient safety issue, or a malfunction which can have an impact, like an instruments which can have an impact to user or maybe patients. So those kinds of an issues, or where the any patient who is reporting it, any complaint, or any customer who is reporting complaints to the competent authority, or even currently in a current scenario, even a cyber security kind of a threat, all these are considered as in mainly a reportable issues. And that needs to be addressed with a proper care, and actions are required for the same, to verify whether the really allegation is allegation is really leading to patient safety or a product quality issue. So those kinds of an reporting mechanism, or those kinds of classification of complaints we do. So for each ca- uh, for each and every complaint which comes to us, we do a proper segregation of complaints, of proper assessment of the complaints, and this is responsibility of everyone, because for the as a diagnostic, or being in a healthcare industry, safety is the most important criteria. uh, Next slide, please. So so what do we have is, when we receive a customer complaints through our call center or from any platform, we register. We have a proper software, which is kind of a customer relationship software. We document each and every complaint properly, and we retain those complaints for quite a number of years. That's almost for 20 years those documentations are being retained. That's the retention period which has been which is being set by the authority. uh, then for each and every complaint which we receive, we do a PRI assessment. It is whether it is a potentially reportable issue. If it is a potentially reportable issue, uh, uh, then it has to be assessed thoroughly well. If it is not a potentially reportable issue, but for the customer satisfaction, but we have to address customer complaint. So we address customer complaint, and solve the issues. If it is a potentially reportable issue, yes, definitely we need to assess, we need to resolve customer complaint, but simultaneously we assess those complaints for adverse event reporting, or basically adverse event requirements. And those definitions uh, are are quite different for different countries. So every country has their own definitions of adverse event. So each for each and every country, even if the complaint has occurred in India, those complaints are also assessed, or potentially reportable issues are also assessed in other countries if they needs to be reported to their authority. So uh, uh, s- uh, so based on their adverse event reporting requirements, they report. But the most of it is like whether it is where there is any kind of a safety issues being reported. And if there is safety issue, is even if it is not a safety issue reported, but the kind of an allegation which has come from the customer, is there any opportunity that this can lead, this error, even though this time it has not impacted any patient safety, but in future if this error repeats, is there a possibility that patient safety can get impacted through these kinds of an error? So that is needs to be assessed and verified. Is there any really a product, such kinds of an product issue, or is there a genuine customer training issue? So these kinds of an assessment is done, and if it is verified, and if it is required to report, that needs to be reported. For India, the India definition for reporting to authority is, if there is any kind of an allegation which leads to, or any kind of a complaint which leads to life threatening, a patient hospitalization or prolonged hospitalization, or if there is any disruptions of ability to conduct normal life function, this is considered as a serious adverse event in India. So those kinds of an events where there are cases which is leading to any diagnosis which is leading to a wrong treatment and then leading to such kinds of an hospitalization, so those needs to be reported to authority. uh, as an organization, but also for any kind of an actions which is generated, or any kind of such kinds of an issues, if there is a verified issues which is related to product or a product quality, then a field corrective action needs to be taken in the field. Maybe a recall kind of an activity needs to be performed, and a kappa needs to be performed to make sure that the product quality is improved. Next slide, please. So this was about a reporting mechanism, and for post-marketing surveys and tools, usually a customer satisfaction surveys are being used as in platform where customer insights has been taken for customer satisfaction, for their ease of business with Roche, and also for net promoter, how they are comfortable or promoting our products to customers. So those kinds of surveys are being taken in Roche take the feedback of the customers on a regular basis, on our business activities, even our service activities, and our performance of our diagnostic solution which we provide to customer. Next slide. Yeah. So, and basically, finally, it is very important that not only as an organization, for us it is very important that we have a proper reporting or a complaint handling and reporting mechanism, is because patient safety, as I said, is very crucial. Finally, as an healthcare provider, simultaneously, if we have a good robust complaint management processes, it helps us to take quick field corrective actions, quick improvement in the processes. It can help improve customer satisfaction. We can have a regulatory compliance, and company reputation is also saved. Um, yeah. Next slide. Yeah. So thank you. That's what I had to present.
Thank
Uh,
you so much, Seema. Thank you. That was a great, presentation of yours. So I just have a question for you. Is there any central data collection mechanism for the, adverse event related to diagnostic safety?
uh, yes. So when you say at the company level, or at the authority level?
Authority level, the regulatory, the central government level.
Yeah, so central in the government level, they do publish the data of such kinds of an events. If it has been reported by company to them, then they take actions, and they do notify through their website about such events, and they also give directions to company what actions need to be taken based on the impact on patient safety. So
Okay.
they can tell you to even take a recall. If company can, they also ask you to show what is the proper actions you have taken for those processes, and even the data is being published into their websites.
So is there any, guidelines that in a year you have to send the data to them if there is any, adverse event related to diagnostic devices? Is there any protocols like a guideline for a year?
Yes. So adverse event, whenever it has been reported to us, there is a timeline. Within those timeline, in company has to report it to authority. And when we take any kind of a and every year we have to submit data of adverse events happening for that product across globe to the authority. So it's, even if you don't report that issue in India, but if there are any such kinds of complaints across globe, for if you have a distribution across globe, then those reports you need to submit it to authority every year.
That was a great discussion. Thank
Yeah.
you so much. Yeah. Now
Yes.
I would like to invite Dr. Mahesh Devnani. He is additional professor and joint medical superintendent, Department of Hospital Administration, uh, postgraduate Institute of Medical Education and Research, PGI Chandigarh. Sir will, deliver the lecture on conveying error and communications and patient interaction techniques. Over to you, sir. We are happy to hear you. Thank you so much.
Yeah, sure, Keshav. Thank you very much. Just give me a moment.
Sure, sure, sir.
Are you able to see my slides?
Yeah, sir. Clearly visible. You are also clearly visible.
Just give me a moment. Okay, wonderful. Thank you once again, Keshav, and good afternoon, everyone. It's a privilege to be here today to discuss an important aspect of healthcare delivery, and which is often very challenging also. And that is the conveying errors and effectively communicating with the patients, especially in the context of the diagnostic safety. Uh, I thank the organizers, especially Dr. Ratna, also for having me today to share my perspective based on my personal and professional experiences over the past 2 decades in the healthcare sector in India and abroad. Not very long ago, this quote from Sir William Osler, who is also commonly known as the father of modern medicine, he emphasizes that the importance of communication in the patient-provider encounter, particularly the importance of listening to patients' descriptions of their illnesses to arrive at an accurate diagnosis. And let me tell you, despite all the technological advancements that we have today in the field of medicine, this quote is still as relevant as it was at that time. So patiently listening to what the patient is saying is very crucial in making the right diagnosis. So let me share a very personal story with you people, and I'm sharing it with the consent of my wife. Uh, my wife once, and at that time she was not my wife, had very severe pain in abdomen, and the symptoms were of a classic ureteric colic. Ureteric colic means the stone in the ureter, that is the tube between the kidneys and the bladder. It was a very severe pain in the right flank, radiating to the lower abdomen and the groin, and it was coming in the waves, which is very classic of the ureteric colic. There was no personal history of stones. There was no family history of stones. So we consulted a nephrologist, and he advised an ultrasound, which we got it done. And the ultrasound was done by a senior resident in the Department of Radiology. Uh, there was no stone in the ultrasound. And let me tell you, the ultrasound is a subjective test because it depends on the skill of the performer, whosoever is performing the test. And the report was perfectly normal. The routine blood samples were taken, and those reports were also normal, yet the symptoms were not subsiding, even with or there was very little improvement in the symptoms with the analgesics that were given at that time. Keeping in view there was no stone seen on the ultrasound, the nephrologist advised us to take a consultation from a gastroenterologist and a gynecologist. So we consulted both of them. The gynecologist said that there was nothing from the gynae side, and the gastroenterologist gave us a long list of medicines along with few more tests to be performed, including a stool test. We did all those things, and she took all the medicines given by the gastroenterologist. 5 days passed by, and there was still no relief from the pain. Pain was still there. So then what to do? So I have a very dear friend who was with me earlier, and he's a surgeon. So I called him and shared the whole story that this has happened and the symptoms are still not improving. And he immediately said, this is a classic ureteric colic as per the description that you are giving me. And you get a CT done, because ultrasound is a subjective test and one may miss the stone in the ultrasound, especially if it is a small stone. So we got a CT done. And in CT, it showed a very large 1 centimeter 1 centimeter diameter of stone in the right ureter, impacted at the upper side of the ureter. So once the definitive diagnosis was there, the proper treatment was started, and the pain was relieved, and later on she was perfectly fine. But just because the diagnosis was missed because of missing the uh, stone in the ultrasound, and then no one actually gave importance to the symptoms that were there and were not advised any more tests in diagnosing that stone, rather than everyone advised something else. So she remained all bedridden and in pain for almost 5 days. And this is just a small example that I'm giving you from my personal experience. The medicine, because being the imperfect science, is full of such examples, and the magnitude of problem is quite huge. Uh, the diagnostic errors are now increasingly being recognized as a key source of patient harm, and that's why the WHO has given the theme this year's Patient Safety Day for the diagnostic safety. Around 5% of adults are affected by diagnostic errors in just in the outpatient environment in the US, and at least 0.7% of admissions involve such errors with common diseases such as the carcinoma and the pulmonary embolism. They are frequently missed. In the US alone, this accounts for an estimated 2.5 lakh errors yearly. And this is just a tip of the iceberg. The National Academy of Science, which was earlier known as Institute of Medicine, in their seminal report on diagnostic safety in 2015, concluded that most people will experience at least one diagnostic error in their lifetime. So you can understand the magnitude of the problem. 16% of preventable patient harm from all sources, I'm including medication errors, surgical safety errors, and everything. Out of them, 16% of preventable patient harm in the healthcare system may stem from the diagnostic errors alone. And according to an OECD patient safety survey of 2018, the delayed diagnosis or intervention is a leading cause of patient harm in ambulatory, that is the OPD settings, and the primary care settings, especially in the low and middle income countries. And a recent report, the review report, also said that the 21 of the patient records from the 21 general practices in the UK identified that potential diagnostic errors in 4.3% of the consultation examined, and 37% of those errors leading to moderate to severe avoidable patient harm. So this diagnostic errors, or the diagnostic safety events as they are called, are quite prevalent, and I'm happy that more and more people are now talking about them, and the patients need to be made more aware. The general public need to be made more aware about these issues so that we can tackle them better, and I'll discuss this in subsequent slides as well. So broadly, these diagnostic safety events can be divided into two categories. One is that the delayed, wrong, or misdiagnosis, as happened in my wife's case, or the diagnosis was there, the diagnosis that there was no problem in the diagnosis was correct and made in time, but was not communicated to the patient, and no follow-up was done, or no corrective measures were taken, no treatment was given based on the correct diagnosis that was made. So that is also a diagnostic safety event, that the diagnosis was made, everything was fine as far as the equipment was working, the patient doctor communication until the diagnosis was advised was okay. But once the diagnostic test was done, the diagnosis was finalized, somehow the follow-up was missed. So that is also considered as one of the diagnostic safety event. And there are so many examples of these diagnostic safety events that happen in the hospital. And I have enumerated some of them here, like failure to order appropriate test. As it happened in our case, that appropriate test based on the clinical symptoms, once there was no stone was seen in the ultrasound, was to advise a CT, but it was not advised. Incorrect test interpretation, many times it happens because many times it is subjective, especially in the radiological settings. The interpretation may be different or it may be missed. There are communication failures, the miscommunication between the healthcare providers or between the provider and the patient. Failure to follow up, patients not being given the diagnosis, or test was done, report is there, but no one has told the patient about that report and what follow up is to be done. Diagnostic overshadowing is also very commonly seen, focusing on the patient's known conditions only and overlooking the new symptoms that could indicate something new that has emerged. Inadequate history taking. It is a problem, as I mentioned, since the time of Osler, that we don't spend enough time for whatever reasons nowadays on the patients, what patient is saying, taking enough history, missing some points in the history, whether it's a personal history or the family history. System errors can also happen, whether it is the electronic medical record or it can happen at the equipment level during the diagnostics. Biases, we all have some types of cognitive biases. We sometimes have, you know, as I said, that the gastroenterologist saw only the problem from the gastroenterology side and gave us a long list of medicines as well as a test. Once the nephrologist said that, okay, nothing from the nephrology side, he only focused on his own specialty, that from the gastroenterology side, if there is a problem or not. And then inadequate physical examination. Many times we miss things just because either the history has not been taken, or based on the history, the proper medical examination or the physical examination has not been done. And these are just some of the examples that I have given. Now, there are various contributing factors that lead to such type of diagnostic safety events. And these can also be, divided into two. One is the cognitive aspects or cognitive factors, and another is system-based factors. The cognitive factors are mainly related to the individual, whereas biases, maybe fatigue, stress, irritability, or some other influences because of the overload of work. And part of it is also systemic. For example, the overload of work may be systemic as well. It can be an individual's response to that overwork, that leads to such certain type of biases, or expediting the things, expediting the diagnosis, or expediting the overall physical examination. But there could be various system-based factors as well, organizational vulnerabilities that predispose to the diagnostic errors. Some examples are, like, as I said, inadequate history taking, inadequate examination or ordering test, performance and interpretation of diagnostic tests, false positive or the false negative, both ways. Follow-up is missed, or the and tracking of the diagnostic information was missed. And then most of the time, there is not just one contributing factor, there is a mix of contributing factors. Now, what are the various interventions that have been recommended based on these contributing factors? So one of the intervention that was widely said is the making people aware that unless you know there is a problem, you probably don't actively seek for their rectification. So educational interventions, making people aware of the problem, making them aware how to prevent them, and making them aware how, if it has been happened, how to prevent its recurrence and take remedial measures. And educational interventions not just for the healthcare providers, but also for the patients and their attendants as well. Personal changes, specifically the way we can handle our stress, and most of the time the residents and the faculty in the hospital, most of them are overworked and stressed because of the nature of the work, the way they come across life and death situations and deal with the life and death situations day in and day out. It leads to certain stresses, burnouts that has to be taken care. If we want to prevent the medication errors, surgical site errors, diagnostic errors, or any kind of medical errors. Then the technique improvement is very important, that we keep improving the technologies and reduce the false negative or false positive results, reduce the chances of breakdown, so their calibration is proper, etc. The techniques, with the introduction of more and more technology, these diagnostic services are keep improving. And then the technology based system interventions, for example, alerting abnormal test results and sending those results to the physicians in time, computer based diagnostic tools for medication safety. Now there are like the drug interactions. If there are any ADRs, they get reported automatically based on the computer based systems. Then the structural processes sometimes lead to these problems. And if we can make those processes more robust, and for example, by implementing triage protocol or the checklist, that can make the system more, better for the diagnostic safety. Additional review methods can be implemented, but they are not always possible because of the shortage of the manpower and many other things. Empowering patient in all this scenario is very important because empowering patient is a critical intervention. In fact, in my view, this can reduce all types of errors if the patients are empowered enough. In our setup, there is big power mismatch between the patient and the provider, and many times patients think डॉक्टर साहब कर रहे हैं तो ठीक ही कर रहे होंगे, अगर नर्स मैडम कर रही हैं तो ठीक ही कर रही होंगी, इनको हमसे अच्छा ही आता है, which is true. But at the same time, there is no harm in becoming vigilant and asking things, which in our setup is a discouraged for whatever reason. So it is very important that we listen to the patients because they are the first one who will bring the problem to us. They can manage, they can monitor the emergence of any new symptoms, and they are the first one who will notice it. So they actually increase the overall, improve the overall critical safety net if they are empowered. By being proactive in ensuring that the diagnostic test results are reviewed and some action has been taken in case the result is not favorable. By actively participating in follow-up and providing feedback, patients can play a significant role in the preventing diagnostic errors also. And encouraging people to raise any concerns or fears without feeling intimidated is important. At the same time, the healthcare worker should also not feel intimidated in reporting those errors. And that only happens when we have a culture for reporting errors, and no punitive action will be taken only just because the error has been reported. Now, this is easier said than done, right? And at the same time, the conveying the errors to the patient is also one of the very challenging tasks. There are no uniform guidelines because it will vary from people to people, because this is an issue of interaction with the people, with the patient, and many a times patients are receptive, many a times they are not. They are uneducated, sometimes they're educated. They come from different socio-economic backgrounds, different educational levels, and whether or not they are receptive to understand what is being conveyed, it becomes a little bit more trickier to convey those errors. At the same time, one has to keep in mind the legal ramifications that may be invited by conveying the errors. But it is always good to convey the errors and how to convey it. So there are no guidelines as such. As I said, it's very varied thing and is a human to human interaction, but there are certain things that we keep in mind while conveying the errors. The first is the preparation and planning beforehand when you are intending to convey those errors to the patient for the benefit of the patient. Because unless you convey those errors, if something has happened, how would you be doing a course correction? So all facts should be with you: nature of the error, how it occurred, what are the potential impacts, how it will be taken care, and it has to be discussed with the team thoroughly before these facts are presented to the patient. Choosing a right setting is very important. It should be a private, comfortable environment. Minimize distractions. Keep your phones away, and keep the doors locked so no one is entering and going out of the room. Um, and be honest and transparent. It is important you come across someone who is empathetic to the patient's need, who is caring to the patient, and not just lip service. So clearly explain the error to the patient, avoid medical jargons, acknowledge that something wrong has happened, and don't try to deflect the blame. Express empathy and apology, and it is important that we explain the impact of that diagnostic error. That may be a very small impact, or it could be a larger impact. And diagnostic error may have happened despite best of the intentions and despite taking all the precautions. As I said, in our case, the ultrasound is a subjective test, and even the best of the clinicians can miss that large stone. So it can happen. So but the proper explanation of that and explanation of the impact of the diagnostic error is very important. Outline the next step, what you have already planned for the patient, encourage questioning and dialogue, involve any support system if you have, whether it inside the hospital or in the community, and involve these support system advocates who can better counsel these patients. Documentation of the conversation is very important, and do not forget to follow up. Just conveying this once is not enough. You had to follow up, be in touch with the patient or the attendant, so that the whatever future course of action you have planned is properly implemented. Now I totally understand this. This all is easier said than done, but this can be done, and we do sometimes whenever we get these reports. Although the reporting of the diagnostic errors is not that often, let me be very frank about that. uh, as far as the reporting for the phase 4 trials post marketing is concerned, that is a regulatory requirement that goes to the concerned vendor. But as far as the diagnostic errors that happen in the hospitals, there are as such no central repository in which they can be given. For ADRs, the adverse drug reactions, there is the pharmacovigilance cell which provides this information to the central registry, and we do take action based on corrective action based on the reports that we receive from the pharmacovigilance. So that is all from my side. And again, thank you very much for your kind listening and for having me here today. If there are any questions or comments, then you are very welcome.
Thank you so much. Thank you so much, Dr. Devnani. That was a beautiful and informative, presentation of yours. I just have a question. In the era of telediagnostics, telemedicine, there is so much, communication gap and communication error happens. As a, doctor and as a health specialist and a public health specialist, what is your insight to decrease the error in the telemedicine and telediagnosis?
So telemedicine and telediagnostic both are more prone to such type of diagnostic errors. Specifically, I'm talking about where the store and transmit type of telemedicine is done. Even in the face-to-face telemedicine also, because the way the patient presents the disease or the symptoms and the way it is perceived, the way the follow-up questions are asked or not. So although I do not have a data, it is a good question. We need to go back and see how big this problem is. But my understanding is this area is more prone to, have such type of diagnostic safety events. Now, how to prevent it? Again, we need, as I said, in any setup, whether it is face to face or through the video conferencing or the telemedicine, we need to listen to the symptoms of the patient. Give him or her the space and time to explain what he or she is experiencing or has experienced. Asking more questions based on those symptoms is important, and then writing those diagnostic tests rather than conveying it to the other healthcare worker who is on the other side of the telemedicine. Sometimes it's not just the patient goes to a site where a healthcare worker, either in a nurse or a multipurpose worker or any paramedical worker, is already available there. So sending those diagnostic tests in writing is more important. But I totally agree that these probably the telemedicine is more prone to diagnostic safety events than the classic way we see the patients. Yeah.
Yeah. Thank you so much, sir. So there is one more question for you, sir.
Yeah.
From Clarinda. So she said, what is the patient's role to avoiding the diagnostic error, and what can patient do to work together with the system?
Yeah, so as I said, empowering patients is very important and is very crucial, not just for the diagnostic safety, but overall patient safety. If the patient's voices are raised, in fact, the last year's theme of WHO patient safety day was raise the patient's voices.
Exactly.
I think many times the hospitals are not even aware of these things, that we need to improve the patient's voices. So there comes the role of many patient advocacy agencies or NGOs that work in this space, how they can, like yours, who can make the patients aware. An informed patient, a vigilant patient is always a ally of the doctor. He is not an adversary of the doctor. he or she can first see something. For example, let me give you an example. एक डॉक्टर ने बताया हमारे को कि जी कल तो जो आईवी फ्लूइड होता है कि जी रोज तो डॉक्टर साहब जो दवाई डालती है, नर्स जो दवाई डालती है वो लाल कलर की थी, आज पीले कलर का कुछ डाल दिया उन्होंने. He was the first one to notice. And then the nurse realized that the bed number she was supposed to give that injection was at next bed rather than the this bed. And because both the IV strengths were there, she injected in the other patient's IV fluid. And
Oh
this
my
was
God.
prevented just because even the uneducated attendant of the patient could see कि ये लाल कलर का दवाई ना होकर के पीले कलर की दवाई होनी चाहिए थी, जो कि दो रोज डलती है लाल कलर की. तो लाल कलर की होनी चाहिए थी, आज पीले कलर की डाल दी है क्योंकि रोज लाल कलर की डलती है. So patients in that sense, once let's say the test have been advised, doctor might forget, the system might forget, but the patient knows कि भाई मेरा ब्लड लिया था 2 दिन पहले, 1 दिन पहले, कहा था 2 दिन बाद आएगी रिपोर्ट. क्या रिपोर्ट आई है, क्या उसमें ठीक आया है कि नहीं आया है, गोइंग बैक आस्किंग दोज क्वेश्चंस. एंड इफ आजकल तो रिपोर्ट्स में ऐसे होता है कि इफ देर इज समथिंग, the value is beyond the standard value, it gets highlighted either in the bold or underline, or in some way those readings are highlighted. So the patients also know that okay, ye is within the normal range nahi hai, then what is to be done, whether this is acceptable or some intervention is required, so that this is not missed. So asking those questions, empowering patients to understand, because as I said, there is a big power imbalance between the patient and the provider. And we understand that there are historical reasons. But making the patients more aware, making the providers also more aware that patients are actually your collaborators and not adversaries when they come up with some suggestions or come up with the problems is very important.
Thank you so much, sir. So I have one more question for Mridula. I think she is here. Mridula, are you here?
Yes, yes, Keshav. I'm sorry, I was speaking and I was on mute.
Oh, okay, okay. So, Bridla, like we are a patient organization and you are also a patient organization. So, what do you think how we can empower, the diagnostic error reporting with the help of the organization, the industry like Roche and the hospitals like Dr. Devnani is working with PJIMR Chandigarh. What do you think we can do to the industry and the hospital can do to get the patient reported their harm?
I think first thing would be uh, easy to access reports, digitization. And by digitization, I don't just mean sending the report over the email or WhatsApp, but also how do we store those in that information, like we have it in the Abha or in other platforms. We can actually store previous reports as well, and that can be collected together. I think that is definitely very important, because if a person uh, comes with a condition, and their history might be very important at that particular time, and they might not have all the papers with them. But starting from that particular point, if we are able to store that information in the cloud, it would be easier for the hospitals, for the doctors, and for the patient also to manage their reports. Another part, I would say, so very very recently, I myself, because I live with type 1 diabetes, I went out for a HbA1c test, and it was from a lab that I wasn't going to. I was going to one particular lab, and always have followed that track. So the other lab showed me very high values, and my I thought that it shouldn't be the value. It came out to be very high. I can't even say that. And when I got a check from the place where I used to go, and it came out to be like far more less than what it was there in the other labs report. So it would be better if we follow one lab, an authentic lab, and get ourselves tested on regular basis. It is not, it, I won't suggest that we switch different labs every single time. Their units might be different, their testing process might be different, and also the baseline that you have started with. Let's say a from a lab, I got it tested every year for maybe 2 3 years, and now I'm changing or switching to another lab. It might not be exactly, there might be changes and differences, and if the lab is not that good, it might also show some errors. And it has happened several times with other people as well in our community. Very recently also, uh, getting diagnosed with type 1 diabetes in itself is a big challenge, because many doctors are there who will be able to diagnose type 1 diabetes, but there are other quacks also who claim to cure type 1 diabetes, and many people get into their that kind of scam and lose those precious times where they could have better managed or understood their condition, accepted the treatment and all. So it is always good that we, as a person living with a chronic medical condition, also connect with patient support groups and understand, communicate with each other, communicate with the doctor the challenges that we are facing, and try to kind of organize our reports and other things in a proper way. That's what I would say.
Thank you so much. Thank you, Mridula. That was a great discussion, actually. We are ahead of time, I think. So, thank you so much, everyone, for joining our webinar. Thank you so much for, the speakers to, get the things done, and the insights which we have brought out from the discussion. Thank you so much. So we are organizing a panel discussion on 14th of September on World Patient Safety Day. You all are requested to please register that from our channels, and please be on the day. Thank you so much, everyone. Thank you, sir. Thank you. Okay.
Thank you, everyone. Thank you.